welcome. Thank you all for being here tonight. I'm Dr. Mitchell, Tiffany Mitchell. I'm junior faculty at Mount Sinai, the Department of Emergency Medicine, and I am the chair of social media and publications for ADIEM. And thank you to our town hall on dual identity, how awareness of racial bias in medicine informs our role as BIPOC physicians. I want to first extend a very hearty thank you to our panelists who are here. Thank you guys for agreeing to take time out of your busy day, just coming off a holiday weekend, to be here with us to have a really good, interesting conversation. So I'm gonna start with a little bit of background, a little bit of context for why we're here and why we're talking about the things that we're talking about. So in 2013, the AMA Journal of Ethics published a review which demonstrated some glaring differences in pain management between white and non-white patients. Black and Hispanics were found to be less likely to receive any pain medication at all compared to white patients, and more likely to receive lower doses of pain medication compared to whites. Black and Hispanics were found to wait longer in the ED to receive any pain medication compared to white patients. Hispanic children who were post-op tonsillectomies and adenoidectomies were 30% less likely to receive opiates for pain management compared to white children. Relatedly, a separate study found that despite relatively low rates of mortality for healthy children who undergo surgeries, Black children were 3 times more likely to die in the first month after surgery compared to white patients, 3 times. This was a huge study. A 2016 survey of 222 white medical students and residents found that over half endorsed belief in at least one myth about physiologic differences between Black patients and white patients. 58% endorsed the belief that Black skin is thicker than white skin. 15% endorsed the belief that Black couples are significantly more fertile than white couples. 23 endorsed the belief that Black people's blood coagulates more quickly than white people's blood. Another 15% endorsed that Black people's nerve endings are less sensitive than white people's. Hilariously, and this is my new favorite statistic, apparently a solid third of white medical students and residents apparently believe that that Black does not in fact crack, endorsing that Black people age slower than white people, which is a new fact that I'm going to drop in a conversation at all opportunities. But the most disturbing aspect of these shared beliefs and these shared myths is that so many of them can be directly traced back to incredibly racist scientific papers from the 1800s. These aren't, ideas that came out of nowhere. The idea that Black skin is thicker than white skin was propagated by Dr. Thomas Hamilton. In the 1820s to 30s, he conducted experiments on an enslaved man by the name of John Brown by repeatedly blistering his skin over and over and over, and then kind of measuring the results. Interesting fact, the modern day spirometer was developed by Dr. Samuel Cartwright, which he used to kind of prove his theories about differences between lung capacity between Blacks and whites. Some of the corrections that he developed about race corrections are still kind of enforced at this day. Dr. Cartwright was a widely respected authority on diseases of the Negro. He published a paper entitled Report on the Diseases and Physical Peculiarities of the Negro Race. In it, he asserts that Blacks had overall worse or poorer lung function than whites, and that it could only be cured through, paradoxically, forced labor. In fact, nearly all of the deficiencies described by Dr. Cartwright and many of the leading authorities of the day either reinforce the subjugation of Black people or described some aptitude for physical labor, which is to say that it's entirely, non-scientific. It's not even remotely objective. There was a very clear agenda from these, purportedly objective scientists and doctors who were conducting studies and writing papers, but there was a very clear, agenda with regards to how they approached non-white bodies. The point is this: even today, the way that we think about and talk about and treat our Black patients, these ideas weren't born in a vacuum. Our medical texts and anatomy books were written by white men who were anything but objective in their approach to non-white patients. So what do we do? So knowing this as medical professionals, the onus is on us to be highly critical, highly skeptical of so much of the information that we were taught as fact in medical school. Which parts of medicine can we safely say were untouched or untainted by the racist views of the scientists and doctors who conducted these studies and published these papers? Which bits are safe for us to kind of rely on? So it's with these heavy questions and these heavy thoughts in mind that we are all gathered here today in what I think is going to be a really interesting and exciting discussion. So I want to thank all my panelists for being here. I'm going to introduce you guys individually. So Dr. Rosny Daniel. Dr. Daniel is a faculty member and assistant professor in the Department of Emergency Medicine at UCSF. He's the director of DEI in residency curriculum and serves on the executive board of ADIEM Foundations as director of DEI. Dr. Minerva Romero Arenas is an endocrine and general surgeon at New York Presbyterian Brooklyn Methodist Hospital. She's an assistant professor of surgery at Cornell Medical College and a founding member of the Latino Surgical Society. Dr. Joshua Elis is a current medical education fellow in the Department of Emergency Medicine at Beth Israel Deaconess Medical Center in Boston. He is the recipient of the National Minority Quality Forum 40 Under 40 and Minority Health Award, the Mayo Clinic Gold Stethoscope Award, Educator of the Year Award, the Mayo Clinic Gold Humanism Award, and the University of Houston's Dean Award. Dr. Marcee Wilder is an assistant professor of emergency medicine at George Washington University. She holds a master's degree in public health and worked for the New York City Department of Health and Mental Hygiene as a research associate and served as an adjunct professor at the Brooklyn College School of Public Health. Dr. Wilder earned her MD at Howard University and completed residency at Mount Sinai School of Medicine. She was recently awarded a diversity supplement from the NIH to examine social determinants of health and their effects on medication adherence and ED visits. Thank you all so much for being here today. I invite you to turn on your mics, and we're gonna go ahead and get started. So I wanna start by inviting you each to share or talk about a time when you can recall race impacted or played a role in the care that a patient received. Anyone can go first.
I guess I can start. Again, thank you for having me. I'm excited to be here and have this conversation, which I think is necessary and pertinent at this time. So talking about being a BIPOC physician and fighting racism, an institution that we're all operating in as a minority, it's hard. And I think one of the things that we can't leave off the table is when we're in training and we don't have the confidence or the gall to call out some of our trainers, it can be difficult when you're watching something happen to a patient and you don't maybe not have the physiologic understanding to say that's not the right thing, but you are watching something that you know doesn't feel right. So my story starts as an intern. During residency, I was working with a very well-respected attending in the department who no longer works at where I trained for residency. But a young Hispanic woman came in with severe abdominal pain. And when I went to present her case to him, he asked me how I knew whether or not she was in real pain. And I said, she's tender on her exam, she looks uncomfortable, her heart Her heart's beating pretty fast. And he said, and I'll never forget, he said, okay, we have to make sure she's really in pain because this could just be status Hispanicus. And the other PA and the other senior resident in the room turned around to me like, yeah, that's a thing. That's a thing. And in my head, I'm like, actually, no, that's really not a thing. But this was a term that they had used to describe what they thought was hysteria from pain that wasn't real pain in Hispanic women. And mind you, I trained in New York City. It's a very, very diverse community, and where our hospital was located was extremely diverse and had more than a 40% population of Hispanic people. And so from the outset now, this highly respected, actually well-renowned person who's well-respected in our specialty is telling me as a trainee that I need to gauge my pain score on this Hispanic woman because she could be in status Hispanicus. So later on, as a jab to him, probably 3 or 4 months later, I actually asked the chief at that time to discuss that pain paper that you so eloquently described at Journal Club, to discuss how it's important that we remember that every patient is different and that we don't judge them based on their race, obviously. But at the time, as an intern, I did not have the confidence nor the knowledge that I have now to be able to put him in this place, right? And so that's another issue that you have with being a BIPOC physician in training, where you're watching people who train you, who are supposed to be responsible for the care of these patients, implement biased medicine.
Yeah. I remember where I trained in medical school, they used to say, oh, she has a case of the ADIEMs. Like that was a thing that I frequently heard.
And I can hop in and go next. Thanks for telling that story. I think that very commonly, once you're aware of these things, it's hard to not see it, right? So it was hard to pick just one case or one instance. The 2 things I can think of just off the top of my head. One is, while I was a resident, I remember trying to learn really what the ESI score meant. And when we triage patients, like, what does that mean? And feeling like there was a lot of subjectivity to it. I've realized that people have a lot of power in their decisions, and there isn't always a fair way to do it. And I remember a night we're busy as always, 20 people in the waiting room, et cetera, 2 different hand pain cases. One was a more stereotypically white sounding name, and they had hand pain from a fall, and they were ESI 3, so kind of middle range. And I remember seeing a name that sounded like probably not a white name. I wasn't really sure. I went and looked, and turned out the patient was Black when I saw them. They had hand pain, and they had a ring stuck on their finger, and there was changes in color to their finger, et cetera, which to me seemed higher acuity. As an intern, I wasn't really sure, but I figured, yeah, it seems higher acuity. And they were put as an ESI 4, so lower acuity, gonna be roomed later, gonna get medications later, gonna get care later, et cetera. And to me, I'll just always remember that case. And it was just such a simple thing, like 2 people with hand pain, same triage person seeing them, and them getting different ESI scores, and that's going to change the whole trajectory of them in the department. And just the other day, I was working in kind of one of our lower acuity attending only shifts, and I was talking with the nurse who I really like and respect, and we had a long conversation because I pointed out that we had open beds. There was a patient who had just been triaged and just wasn't getting roomed. And the triage complaint said chest pain, which, I mean, just room the person with chest pain, we need to see them. But then the other comment was they are schizophrenic and off meds. So we have to always talk about intersectionality in this because there's so many aspects that matter. But just seeing that, I thought, well, that's kind of weird. And I went and saw the patient. It was a Black man. He was mid-30s, and he was very calm, cooperative, just hanging out. And I had a very normal conversation with him, and just saw him in the waiting room, and then went to the triage nurse and asked, like, hey, why isn't this patient roomed? And they're like, oh, I don't know. Let me get them roomed. They eventually got them roomed, but I had a conversation with another one of the nurses, and they basically told me, like, oh, well, like bad things can happen. And I thought, well, like, yeah, bad things can happen with anyone, but just because a person has a mental health disease and is a person of color doesn't make them dangerous or not deserve care.
It doesn't mean they aren't also having a heart attack or
exactly.
aren't
This was a miss too, because this guy hadn't even had an EKG yet. Wow. I checked, I'm like, why? And it turned out it was really more abdominal pain, which was fine. He was low risk, but at the same time, like, standard of care to get an EKG. It's not hard to do.
Yeah.
Super simple. And you mentioned intersectionality, and the story that came to mind first was actually a patient of mine in a labor and delivery a rotation. As an African-American woman, but she was HIV positive. And so she actually bought pizza for the entire staff after her baby was delivered healthy and everything. And I remember one of the mid-levels peeked open the box, like, who bought pizza? And we discussed with her about it, and she closed the box and says, I'm actually good. And made a comment that, oh, well, she's HIV positive and Lord knows where she's been. And it's so tough when there's an intertwined, like the stigma behind HIV and also this race thing. And I remember being an intern completely in disbelief and shock and having that fester so much longer after the fact. And so I definitely experienced those. And you mentioned like the triage scores. There's so much data to support that there's so much bias in the way we're triaging our patients, and also with the stigma behind HIV. So this is certainly something probably anecdotally a lot of us can profess to.
And it's concerning because we're medical professionals. We actually know better. We know that there are very specific ways that you can contract and transmit HIV. Like, these are all medical professionals who know better. And the fact that it still kind of persists, how can we expect the public to kind of shed that stigma if we still harbor it incorrectly?
And then just the fear of how much that feeds into your day-to-day interactions with this patient. Right. And this patient was doing something benevolent. And I think that was the harder part, was like, Jesus, she just bought us the whole office pizza. We're all eating and congregating in the room. And you probably had this person probably had the most direct contact with the patient, unfortunately, just had that comment to make. And it just makes you question every other aspect and part of the care process.
And I think something that's come up in kind of all these stories too is what position of power we're in when we see these things and when they happen.
Yes.
And it's really hard. I still struggle. I would like to say I'm really good at these conversations, and that every time a microaggression happens, I stop them and, you know, I hand them a card about racism and tell them to read Obama's book, and we, like, you know, kumbaya. But that doesn't happen, right? Like, these conversations are difficult, and there is some aspect of protecting your own professional identity. Because you don't want to be, I'll speak for myself. I don't want to be known as the person that always blah, 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 right? So I don't want to have an issue with an entire staff because I'm a person who's always bringing something up. So I try to be really thoughtful about it. I recently did a workshop that was fantastic, talking about how to have difficult conversations around race, bias, identity, et cetera. I'm still working on it, and still something I think we all need to get better at. And what I've learned is, you know, silence is violence, and trying to be better about it, but it's difficult. And I think that, I don't know if people do it on purpose, but certainly I feel a lot more empowered now as like the only attending on certain shifts to call these things out, rather than when I was a medical student or intern and I would witness things happening to me, to my colleagues, to my patients, to custodial staff. You know, it's not just like our patients this happens to, it goes to everybody that's part of the hospital system.
I think you brought up a good point. Oh, I'm sorry. Minerva, you were going to speak.
Go ahead.
I was just saying, I think Rosny brought up a good point in that how we react to these microaggressions, or even things that we see bias against our patients, depended on the level of power that we had. Because obviously we saw all of these microaggressions in different stages while we were medical students. I'm sure we all did. We saw evidence of bias against our patients. We saw it as residents. And it was just harder to be able to speak to our trainer or whoever was responsible for our learning, because at the end of the day, these people are still also responsible for you matriculating through their program, right? And you don't want negative feedback, you don't want retaliation. And so calling out, it's a very tight dance where you want to call out that attending who probably shouldn't have done that with this patient, but then they're going to be writing your remarks for your, you know, milestones. And so it's different now as an attending, you know, microaggressions against me, or, you know, comments that people say in the back, I don't care about, but I will always defend my patient. Or if I see bias happening in front of me for someone that I am legally responsible for taking care of,
right?
You know, that has to stop. Or if a nurse, you know, or someone that is, you know, under me in the department is treating a patient a certain way, and the patient just doesn't feel comfortable with that nurse, you know, it may not have been something overt, even the smallest microaggression. I will ask politely for another nurse to take care of that patient, because they deserve to feel comfortable and safe during their ED visit, you know?
Yeah.
But I have that position of power to do that now, right? When of course I did not as a resident or student.
But I think that even within that position of power, and I'm, a very new attending, I think that it's still kind of, if I were, you can't fight every fight, right? If I were to address every single microaggression that I'd never get anything done. I'd certainly never get any medicine done. And it's frustrating because, now it's like, all right, well, let me do the research. Let me find the paper to prove why this was incorrect. And let me circle back and let's have a lecture, let's have a talk. And it's a lot of work. And all of it is really kind of, it really does, it's distracting, but it's necessary. And it's important. And I think that unfortunately, and the onus does fall on our shoulders a lot to kind of be the champions, for every person of color, every marginalized person in the ED, because you see how insidious it is and how pervasive it is. But it's a daunting task. And I know there's been plenty of times in ED where I've just been like you would start and you're like, I don't have time. Like I gotta keep going. Like I don't have the time to explain to you why that was incorrect. But I do think that there's something to be said for trying to model good behavior. And, I think that the most important thing is I think showing people how to do something is 10 times more effective than telling them how to do something. So, if I see, one of my nurses is being very abrupt or very kind of nasty to a sickle cell patient, I'll come in and be extra nice and extra accommodating and say, really kind of attentive to their pain and just kind of try to model that. I think that in a lot of ways that can be effective as well.
Well, I think it's really important, the point that you made about having to go back and educate ourselves, because, part of the reason why we're doing that is because there was really nobody to model that behavior necessarily for us, right? And so when these situations sort of came up in training, and even now as an attending, how do I manage this? And it has gone down to having to look some of the things up. So I mentioned I'm a surgeon. As a resident, I often interacted with patients, of course, in trauma setting. And one of the things that I always found myself really sort of fighting, and it took me a while to sort of find the way to sort of protect the patients. But trauma patients come in, oftentimes they're involved in some sort of crime situation. I'm not saying they're the perpetrators, but they're involved, and the police want to come in and ask questions. And I always felt like it was a very invasive and sometimes very aggressive approach. And so I oftentimes struggled with how can I, draw this line that my focus right now needs to be on the medical care of the patient. And unfortunately I have to, what feels like I have to delay your investigation. But if this patient dies, you're not going to have any information. And so I had to sort of really look at what kind of policies were available and what I could, what were my protections in terms of how I could keep the patient medically safe, but then also how could I not interfere with law enforcement, right? And particularly, I thought it was really important with patients who were minors and, who do have the right to be questioned in front of a parent and not on their own. So, unfortunately, I was like playing doctor, playing lawyer a little bit, but I thought it was really important to advocate for the patients. And now as an attending, but actually, in my most recent job, I actually practiced near the border and had a lot of patients who came in as detainees of Border Patrol and Homeland Security. And it actually took me a few tries to really be able to get the security officers that were accompanying the detainee, who is my patient, to step out of the room, to give the patient privacy, and to give them the dignity of having a private physical examination. But it took a lot of self-education on how can I do this and how can I not be, jeopardizing my staff. How can we do this in a way that the officers will feel comfortable? And sometimes they would push back, saying, oh, well, I can't step out until I have my supervisor give me permission to step out and whatnot. But unfortunately, we really have to sometimes take these stances, and it feels very confrontational.
Yeah, absolutely. So I want to move forward. So all the people on this panel are people of color. That was by design. And as such, I think all of us kind of hold a dual identity with regards to our identity as people of color moving through the world, and as physicians and doctors who are part of this kind of privileged class. So, and perhaps even like, so we have this dual identity, and perhaps even a triple identity if you factor in, sexual orientation, gender identity. So that's to say that the political is frequently personal. Can any of you reflect on a time when a family member was ill or in the hospital? And were you concerned? Were you worried about the care that they were going to receive? And what did that feel like?
I don't have a specific time in the hospital per se. My dad's Black. He's from Haiti. My mom's white, and most of my Haitian family lives in Haiti and some in Florida. In a very different medical system, as you can imagine. But I do remember being on a flight to Haiti with my dad and seeing, this isn't in the medical world, but just seeing that how rude people were to Haitian folks, like the people working on the flight, because they didn't speak English and were just like really rude. And he actually made them apologize to, like he made some of the staff apologize to the people who were on the flight. And it just has always made me think like, well, yeah, I mean, you can be whatever you are and you can like hold so many identities, and who knows, like maybe these folks who spoke a different language, like, I don't know, they could have been lawyers or doctors or whatever in Haiti, right? And held this, but who knows, they get treated away because of what their phenotype is, right? And I think about it for myself. I wonder like, what if I showed up somewhere and I had a stroke or something happened and I couldn't talk, or for some reason my faculties were gone, like would I get treated fairly? So yeah. I definitely have thought about it for my family. Fortunately, as a physician, I'm in a place of power where anytime my family does have to go to the hospital, I'm able to talk to staff in a medical and scientific way and use big words and et cetera, et cetera. But I do always think about that for myself. Like, what if something happened and I couldn't speak for myself? How would that work out?
My third year residency, my mother had chest pain and texted me while I was on shift and said, I really don't feel right. Something's wrong. I don't want to go to the emergency department. Mind you, I grew up in the 80s in New York City. You don't do the ED unless you're dying. Like the wait times are 15 hours. You never go to the ED. So my mom asking me or telling me that she wanted to go to the emergency department actually was pretty concerning to me.
Yeah.
She has some risk factors for cardiovascular disease, and she's in her 60s. So I said, okay, Mom, go, when I off shift, I'll meet you there, so on and so forth. I told her to take an aspirin, and she went to Columbia Presbyterian. And so I got off work at 11. I Ubered uptown to get to her, and she was laying in a bed in a stretcher in the emergency department. Now, mind you, I'm an ED resident, so I understand it gets busy. But she had not had an EKG yet, and she'd been there over an hour, and no one had drawn any labs, and she had not.
You froze up a little bit.
Is she still frozen for you all too?
Yeah.
She ended up having an EKG, obviously had some blood work, and her EKG had some pretty concerning changes from what I knew her last EKG looked like. And the intern was ready to discharge her. And I don't believe that the intern had discussed this case with their attending yet. So that's when I pulled the doctor card, like, hey, at that point I was a chief. I'm like, hey, I'm chief resident down at Sinai. This EKG and her pain that she still has probably, shouldn't be discharged at this time, and had to have an entire discussion with the attending in the ED, who then decided to admit her after meeting me. Furthermore, I had to have even another discussion with the cardiologist, who at the point wanted to just medically manage her. She had never had a cath, never had any invasive studies, never had a stress, nothing. Who thought we could just trend serial troponin. And I'm like, if that was your mother,
right,
with her risk factors, would you have done that? I had to advocate for her to have a cath, and she actually had a pretty significant occlusion that required a stent, right?
Wow.
And so why did I have to do that for her? Why couldn't she just have that care without me? Why
Right.
couldn't she have an admission and a cath without me having to be there, flashing a name badge, just getting off shift in my scrubs to say, I'm a doctor, take care of my mother?
Yeah. I think we all, like, it's terrifying. It's terrifying. What would have happened if you weren't there? She would have been at home just waiting for,
Yeah.
the 100%
Just
occlusion.
infarcting away.
Yeah. Just, right. Sent home with Pepsi.
My brother's wife just gave birth to my first niece, Janae, and this was in August, and it was an incredibly exciting moment. But unfortunately for our family, they had already completely lost faith in the American health system, and so they decided to do an at-home birth using Google and being across the country and hearing this and just wanting to advocate that American healthcare is something that they have access to and that they should take part of. Was probably the most painful part, and how helpless I felt, like, and
Yes.
How true what they were describing, how concerned they were, and how valid their concerns were, and that I couldn't possibly address those concerns from across the country. Fortunately, everything worked out fine, but I think that's probably the biggest fear I have, is that, like, the next time you guys seek healthcare, or the next time a family member seeks healthcare, they're discouraged to do so, right? They're not feeling like they're getting the full benefits of the American healthcare system. And secondly, they feel like they're being disrespected and poorly treated in the process. And I think that was, like, just such a big wake up call, and to see that these statistics hit home for the first time. And I have young parents, everyone's been healthy, but to have a family member who's as close to my brother and my now niece to be part of the substandard of care, specifically because they're Black. I couldn't put it any other way, that they're not getting the care that I'm training to perform on people, and that I would ask for them to have, and their only reason is because of the concerns that they have as being a Black member of society. And so it's definitely terrifying to think.
Yeah. And the helplessness that you felt, I think that's very real. Of, you want to encourage them and say, no, go to a doctor, and then you do the research, you're like, oh, the data's actually not really all that great statistically. And so you really do feel kind of helpless. We want patients to have trust in the medical system, but that trust has to be earned.
There's an interesting kind of thread that keeps coming up, is like this idea of statistics. I think that people try to kind of pride themselves on, evidence-based medicine, et cetera, et cetera. First of all, there's a lot of problem with data, I will say. So evidence-based medicine is hard to practice. And just a few quick comments. I think in terms of race, it's been used as a proxy for genetics, where race is not really genetics, right? So
Absolutely.
Yes, absolutely.
you could be Black, or you could be, I don't know, from Puerto Rico or Senegal or from Germany, and have the exact same, very similar genetics, different than someone who actually grew up in the same country or whatever it may be. So that's one interesting thing. A second interesting thing is that although we kind of know that race is is a risk factor for certain things, some diseases, sure, but a lot of things like, getting restrained in the emergency department if you're Black, having worse like maternal outcomes if you're Black, et cetera. It's really interesting to me that, like, there's still so many people that are not convinced or don't think it's real. Yeah. And it's like the data is there, and for as much as people claim to know evidence and practice based off of statistics, et cetera, there's so many people, I think, that just choose to not come to these conversations, not be a part of it. And, like, why am I spending my time convincing people that the numbers are the numbers, right? Like, it's
Rosny,
crazy.
I think that important thing that we're also remembering, especially about data, is so much of our data and so much of our research paints the picture of race as a proxy for a biological cause. For Black men having higher mortality from CHF from the time they're diagnosed, something must be inherently different about Black men, instead of discussing the fact that race is a magnet for racism, right, and poor social determinants of health, which then affect health outcomes, right? But we have all this data and all this research that continues to push the the almost mantra that we are inherently different biologically somehow, right? We haven't unlocked the magic key to describe what it is, but somehow we're inherently different, and that's why we get sicker, not because we are marginalized, and that's why we are sicker. And so the people that you were talking about, they hang their hats on that data. They hang their hats on the last journal, New England Journal of Medicine, paper, to say that, oh, well, this is why, oh, because they're less adherent to the medications. Oh, well, because they have less access to care. Well, that's because their race is a factor, a risk factor for those very things that cause these poor outcomes.
And ignores the fact that race was kind of born after racism, that
Right.
the entire category of Black and whites didn't even exist until after, the institution of slavery, and was really kind of designated and defined by people who had a very vested interest in making sure that their kids could never be slaves and could never be subjugated, while others absolutely could and would be. It completely ignores the fact that, the way we even talk about race is still very much a function of something that was manufactured and created by design.
But it affects us very much so, right? It affects us not just as
very real,
clinicians, it affects us as family members. It's our whole dual identity. It affects us as people going to and fro, like when everything happened after George Floyd, my thought about, the backlash and all of the, outpouring of support for Black Lives Matter is, it doesn't matter if my husband can still get shot going to Target, right? None of that felt genuine to me, because I have a real fear for the safety of my family members.
Yes.
Right. And so that is my dual identity. I have to go to work and treat people and take care of them while I'm still worried about my family at home. That's my dual identity in this country as a Black woman, right? I'm worried about my children, making sure that they are safe. I'm worried about myself as a Black woman and a patient. I am currently pregnant with our third child. Big surprise. But I had to have a really significant conversation with my OBGYN, because there was a huge study that says that I should be on baby aspirin, and she never offered it to me. I have 2 risk factors. I'm advanced maternal age and I'm Black. And the paper was very clear about having 2 or more risk factors, starting patients on baby aspirin to prevent preeclampsia. And when we had the discussion, she said, oh, well, I just didn't think about it. So if you're not thinking about it for me, that means you're not thinking about it for the rest of your patients that are at risk. Yep. So you're literally not practicing evidence-based medicine, and you are basically putting your patients at a higher risk, which is, I ended up switching from that OB, and I've just made it a goal of mine to have all of my practitioners be people of color, because I as a patient, I am scared of my own mortality, and I'm a physician.
Yeah, absolutely. I can absolutely relate to Joshua in the sense that, like, I have people in my family who really have a deep, deep distrust of the medical field. And I frequently encounter patients who have a deep distrust of the medical field and have no problem telling me so, even as they're sitting in my ED and I am their doctor and they are telling me exactly how little they trust medicine. What is your approach? How do you approach patients and friends and family members who just flat out, really kind of are hesitant to engage with the medical field at all?
I personally ask my family members, to make sure that they are engaging with someone that they feel comfort with, their primary care doctor, their specialist. If they have to find one of color, I've helped refer a lot of my family members to people in New York that I trust, that I've met or worked with. If my family member may text me and say, hey, I had this weird interaction with my cardiologist, so on and so forth. I'm like, let's discuss it, trying to encourage them to still seek medical care when they need it, and be compliant with the medication regimen or whatever, that they have to do to stay healthy, but find someone they trust and have rapport with, right? Because we know that trust that's established ends up leading to better outcomes for every patient, right? And so on an acute level, when someone comes into the emergency department, they distrust me, they distrust everyone, especially as a person of color. I do try to spend extra time at the bedside to build that rapport, right? I remind all my patients, not just my patients of color, but all my patients, that I treat everyone like they were my family member, and I would do for them what I want someone to do for my mother, my father, my uncle, so on and so forth. And I've carried that through from residency. But I will say, I actually got written up in residency for that. I found in my residency in my community hospital, Black men were restrained much more often than anyone else, right? They were restrained, they were sedated, and it was like no one even tried to redirect them for whatever it was for. And I ended up doing that a lot as a resident, like getting to the bedside saying, hey, you know, let's talk for a second. What is the issue here? Are you feeling like you're being ignored? How can I help? Because your escalation in your behavior is making everyone alarmed, and I want to help you, you know, and it'll be like, hey sis, you know, that nurse was really rude to me, said blah, 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 you know, and trying to de-escalate them before it ended up, you know, the attending just ordered them Haldol. I did that a few times, and I ended up getting really bad remarks on my third year eval from attending saying that they thought I took too much risks, that they thought I was engaging in risky behavior by trying to de-escalate these situations. And I'm like, these men look like my uncles, like my cousins. These men look like men I grew up with. This is my community, right? So they don't scare me because these men are from where I'm from, right? But they scared my attendings, right? So to my attendings, I was in danger, but I was never in danger, you know? And so that's part of the dual identity of being a physician of color when you're trying to advocate for patients, but everyone else sees something different from that interaction. So.
Minerva, have you found with patients in the surgical field that you have similar encounters where people are really distrustful or not adherent or really kind of, you know, concerned in those ways?
Yeah, you know, unfortunately, we definitely see that. And there are patients that are coming to us to some degree, not by choice, but also when you're trying to have some sort of elective procedure, it really matters how much trust you can place in the team. And I actually recently had a patient with a pretty significant condition that required a major operation. And we had a little bit of mistrust in the team that really escalated the situation. You know, the patient wanted things explained to them. Why are you giving me this medication? Who are you? Why are you walking into my room at 6 a.m. when I'm half dressed? And, you know, and unfortunately, it really put a strain on relationship with some of the team members, to the point that the patient almost refused to be seen by anyone other than myself and specific staff. I do always try to, with all patients, try to acknowledge their concerns, of course, but also I really try to use that as a learning opportunity for the rest of the team. And we ended up actually having the team apologize to the patient regarding all of the different interactions that were negative and how it was really impacting that patient's care. And thankfully, you know, it built that bridge to where the patient allowed them to engage in her care again. And actually, later in the week, the patient actually ended up apologizing to the team and saying, I'm just stressed out by what's going on. And, you know, and this is not me, you know, I'm not rude. I'm not whatever. I'm a kind person. And so I'm sorry I treated you that way. You know, which I thought, you know, it's unfortunate that the patient was put in that situation where they felt like they had to apologize. But I also thought, you know, the team certainly learned a lot from being able to acknowledge subpar interactions and being able to sort of bridge that gap and build that bridge to sort of reestablish that physician and patient trust.
Yeah, I think that there's so much that we could learn if we paid a little bit more attention to like the soft skills, right? Like I think that people, especially throughout residency in emergency medicine, really want to learn like chest tubes and intubations and blah, blah, blah. Like you'll learn that stuff. Like it's all going to be there. You'll be fine at it pretty much no matter where you train. I think you'll get good at those things. But how do you do the like 85, 90% of what's really important, which are those interactions with staff, with patients, with colleagues, et cetera. And one thing that I try to do for folks who are, you know, mistrusting or whatever, I say like, you know what, you're right. Like you have totally have reason to have mistrust or have frustration. And I agree with you that those are true things. And I want to care for you now in this moment and try to be the best physician I can be for you. Our team wants to treat you well. So, you know, I think acknowledging that, not acting like it's not true, because I think that's the biggest issue in terms of creating and perpetuating institutionalized racism and structural racism is like, we are all part of it as institutions, but what makes up institutions is individualized people, right? So like, I need to acknowledge the moments that I am racist or that I am biased, because it happens and it still happens, and it doesn't define who I am. But I have to say like, oh wow, maybe I did this thing because I was being biased. Like, I need to think about that more and change what I do. And that is okay. I don't have to like hate myself for it. And I think that more people need to stop being so defensive about these issues and be willing to admit like, oh, there's an issue and we should work on it.
Yeah,
There's a question.
I think Rosny.
Come on.
Yeah, I think you brought up such an excellent point, and it's tough when the culture of like, there's so many external things that are present that aren't necessarily even tied to racism. Like, for example, in some of the small rural ERs here in Massachusetts, many of our nurses have like a blue flag with a stripe on it, and the security guard has this on, and the EMS personnel had that on, and you have this African American patient with an all-white staff, all-white things, and there's tense engagements here. And I don't fault them for immediately leaning into this idea that they could be treated differently on their race, right? Like, everything socially and politically in society paints that picture. And here we are in an emergency department. Thankfully, I'm always thankful for the opportunity to be the physician at that time, especially given the fact that within our own practice, we're not that diverse to the standards I would hope for us. And so, I mean, immediately going in there and validating them, because on the best day, they have reasons to doubt that their care would be up to par, right? On the greatest day, they had reasons to doubt that the way the nurse was speaking to them was potentially wrought with judgment or negative energy or anything along those lines. So those soft skills are overcompensating that entire culture, right? And we have a culture within the emergency medicine that, and I'll be the first to point fingers at ourselves, is like the Gomer blog, right? Get out my ER blog, right? That's what it stands for. This hard, I'm a badass, or, and sorry to use poor language, but that lends itself very easily to that distrust, right? And it may not be targeted and may not be malicious, but I try and reverse that in every capacity, right? And I think Mayo Clinic did a good job of training me and pushing me and making sure that there's gentleness in my care and protectionism in my care, and making sure that I'm overcompensating things that no one on the team even has control over, but hopefully we can address them regardless, right? And so,
yeah.
At the end of the day, you know, people know when you're being treated with dignity or not. People know when that person across from you is showing you the respect and the dignity that you deserve, and when they're not. And, you know, and it can be anybody on the team, not just the doctors, not just the nurses. You know, it can be something as simple as the tech. Had a patient complain that, you know, they were transported without a blanket, you know, and it's just a matter of all of the little things that we really think, you know, are maybe not as grandiose and maybe don't have as direct clinical consequence, but it does have a big impact in how the patient views that entire healthcare system.
So there's a question in the chat about how our institutions are navigating details of placing value on BIPOC faculty perspectives and lived experiences into real faculty advancement opportunities. So clinical buy-down, recruitment efforts. And also, you know, if we have any ideas on how to keep the diversity, equity, and inclusion trend going so that it's you know, here longer, and so that it's not just a trend. Have you guys found support at your institutions? I guess it's say no.
At Beth Israel Deaconess Medical Center, I think there's a huge cultural rift in diversifying our practice and making sure that everyone's on board with it. And I think for the most part, everyone is on board, but there are certainly growing pains to this, right? We're certainly having to find out, now that we have access to it, a more than one African American resident in our residency, that what it takes to support residents of color, women residents, and what it means within our practice and the culture of how we communicate to each other now that there are women involved and people of color involved and members of the LGBT community. And so I definitely hope that having the initial presence is going to beget more diversity, the snowball effect. But my biggest fear is that our pipeline isn't broken, and there's so many pipeline gaps in there that we have to push forward that by the time they get to the residency, it might be a little too late to try and push our diversity initiatives. But ideally, you mentioned a big insecurity of mine is that this might just all be the energy of the hour and that everything's exciting now. But my goal is that we push so hard on this hour that there's enough people in place to continue it on, and that those people have built up support systems within each practice, and that within those practices, those people are bringing so much attention to the way we treat our patients, which is the final outcome, right? We want to do all this in the name of patient outcomes and bettering the health disparities that our patients suffering. So
I could go on for about like 25 hours about this, but I think a couple of quick points. One is like, what do we value and what gets paid? And it just drives me like absolutely bonkers what gets paid and what doesn't. Because some people will take, sorry to say it, but truly like useless jobs on committees in the hospital. Like, oh, I'm on this committee and that committee. It's like, oh, you get this buy down. And it's like, yeah, everybody knows how to like push propofol. It's not that hard, but you're on this committee and you get time bought off for it. But people who are doing like real work and having difficult conversations and doing recruitment and reading every application and like going out of their way to make phone calls and this and that, like it doesn't necessarily get valued. And that drives me nuts. So that's why I only want to be a part of institutions that like say like, hey, what do you do for this, right? And like, what does it mean to get advanced like through your academic career? Am I only going to be advanced if I do research and write papers? Like, is that fair? Or what about if I recruit a really diverse resident population and create like change for our patients and help with equity dashboards? Like, is that not as valuable as writing a paper about like, you know, Haldol versus Zyprexa? Like, I think it's probably more valuable. Right. So I think thinking about what we actually value is one really important thing. And two, I think is establishing positions that are going to be consistent. So not just hoping that someone does it, but saying like, hey, we have a chair of diversity or a chair of like, you know, like a women in medicine group or whatever it may be, to make sure that all these different communities that have been, I don't want to say underrepresented in medicine, because I think that term isn't fair. I'd say traditionally excluded from medicine are actually like brought into the picture more.
Yeah.
Yeah, I think one of the things that I'm certainly concerned about is that this is a trendy topic, and that over the past few months, you know, I've been invited to join a variety of DEI talks, DEI committees, and actually, I want to say that I'm currently a part of like 6 different DEI committees across professional societies and hospital committees. And so it definitely is something that I'm very closely monitoring for myself, because I do worry that it's going to take away from my primary clinical focus, from my primary academic and research focus, which are still very important aspects of my professional career. But now I am also pulled away by having to devote specific time on this committee and that committee, you know, which is meaningful work to me. Otherwise, you know, I would have found a way to maybe politely decline. But I also know that, you know, I'm the only, you know, Hispanic woman surgeon, you know, in my hospital. I may be one of 2 or 3 in the entire institution. And so I also know that, you know, that it is important to have someone share that perspective, because if I don't, then unfortunately we're not in a position where somebody else will necessarily provide that. And we're not in a position where so much of the leadership can really drive this. Unfortunately, that these type of committees are not funded, and so we're being asked to create programming without a budget, being asked to create lecture series without the ability to provide any kind of per diem to speakers. And at the end of the day, who knows how it's going to be valued in our annual evaluations.
Minerva just gave a whole sermon. I'm in the same boat at GW. After the George Floyd situation, our dean convened a anti-racism coalition, so the ARC, and recruited deans not just from the medical school and the hospital, but from the undergrad as well, because they wanted to create a culture of anti-racism across the whole entire institution. I was invited, a lot of other junior faculty from all different specialties. We had multiple meetings. Now we have subcommittees, and there are different subcommittees working on various notions, but this is going to take a significant amount of my time, right? And so does this actually also just add to my burden as a clinician, as someone who also I'm trying to pursue my own academic path. Now I have to take on this work for free, right? It doesn't bind on any of my hours. It's something that I'm passionate about, but are you not just perpetuating my own marginalization by asking me to do free labor, right? So it goes back to what Rosny said about value, right? So it's a hot, trendy thing, and everyone wants to talk about diversity, inclusion, and anti-racism work. But my institution, although it appears they value it because they've pulled over 130 faculty members from different parts across the institution to make this coalition, but none of us, there's no budget for it, right? None of us are having our hours brought down by our respective chairs. So is there really value in this work that we're doing? And unfortunately, and I think Dr. Lowe had just said it in the comments, that it does really fall on the shoulders of BIPOC physicians, most institutions that are doing this work. You're going to be hard pressed to go to an institution and find it to be mostly non-BIPOC physicians doing this work, and they're all doing it for free. And I think that just further puts us behind the eight ball, because now I'm working on this work instead of writing my next grant, right? So now, am I going to be ready for my next promotion in exactly the 5-year goals that I have? Or am I going to be pushed back because I'm doing this free work?
We were talking before the meeting started too, about kind of like how things are going for us here, et cetera, et cetera. This has been like a weirdly successful year for me professionally. And because I've been talking about this stuff and doing these things like since forever. So it's not a new thing to me, and it's not trendy for me. Like, this is what my like dedication to my career and what I'm very serious about is. And it is really interesting to think like of how many things I've been invited to, and people have been asking stuff because they're like, hey, did you hear about racism? And I'm like, oh, really? Like, oh, I heard about it like since I was born, since forever. So the idea of like, I think, people of color as physicians, or physicians of color having to like, or I'd say physicians from traditionally excluded groups in general, right? Like trans physicians and LGBT physicians and, women, et cetera, people who come from families where there wasn't a physician in the family. Like, there's so many people who I think have different and unique perspectives and have always had to think about these things, right? This is the minority tax, and this is the increased burden, is along with all the other things that you're thinking about during like from the start, from like high school to college to medical school, et cetera, or any path you're taking. Like, in addition to having to pass the test and do these things, you're also thinking about like, okay, well, I know racism exists, so how am I going to navigate, this interview I have with this person, or this interaction I have with this professor, or if I'm going to say something to stand up for someone, am I viewed as like the angry Black person who's blah, blah, blah. So I think that those things are always happening, and I'm happy that people are talking about these things now. And I'm just like, I really believe in the youth, and the youth really challenge me. At UCSF, the medical students are like, it's Gen Z they're wild, and I love it. They're challenging me on like so many things I never even thought about. And I think that things will continue to change. And I'm just like hoping that this does continue. And I do have like belief that it will. And I just hope that I'm empowering the people that I work with to increase the kind of like diversity and inclusion and really like justice within the pipeline.
So speaking of the youths, there was a question in the chat about any tips or resources for trainees, so I guess for medical students, particularly with regards to developing those soft skills and identifying institutions where we may be truly supported. So I guess finding institutions that are supportive. Do you guys have any tips or ideas for how to, number one, how to develop those skills, and also when you're applying to residency, I guess how to find an institution or identify institutions that will be, you know, supportive in their values.
So I think this cycle, you know, certainly doing the virtual interviews has changed tremendously the landscape for students, right, applying to residency. One of the things that you can definitely take advantage of is all of these virtual programs that a lot of the residency programs have actually developed to try and help you interact with them in a way that really hasn't ever been done before. But also, I think, gives you a better idea that you simply can't get since you're not able to travel in person, to be able to interact with the current residents and faculty, and to be able to get a sense of what those things are like. And then also know what are the formal and the informal things that are in place. There are a lot of institutions that are rolling out initiatives to help increase diversity, to be more inclusive, you know, but at the end of the day, the truth is most of our institutions are not there yet. And so you also have to manage your expectations of what does that institution look like to me. I had a lot of students where I was practicing questions and practicing interviews, and a lot of students would say that their question for interview season, one of the, you know, main questions they want to ask is, what's your institution doing about DEI efforts? Which I think is great, because I would have never maybe had the audacity to ask that during my interview, you know, for residency many years ago. But I also, you know, and while I think it's a great question, you know, I also talk to them about what do you expect that answer to be? And how is this gonna change your perspective on that specific program? Because chances are this is what they'll respond. And you just need to know where we're starting from, if this is supposed to be the beginning of the change in the changing face in healthcare, and how is that truly going to influence your decision to train there or not.
Absolutely.
I definitely, sorry, Marcee, you were about to say something?
Go ahead.
Okay, I definitely commiserate. Like, I remember going through the experience of having to choose a residency program and having to really question which residency program is going to be comfortable for me. Coming out of Howard University College of Medicine as an African-American male. And like, for perspective, my parents didn't brag about me going to medical school. They bragged about their son being at Howard. And it was the only medical school I applied to, which I don't recommend to anyone, but I was dead set on going. And then I went to the Mayo Clinic, which is in a city that is roughly greater than 85% white, in a residency program that has a difficult time recruiting because of that fact that it's a small town. And also some of their initiatives weren't put in place a decade ago, and that might be what it would have taken to have the diversity that they're seeking now. But I would encourage everyone just to understand that, like, yeah, it's definitely going to be tough, and that especially as you're interviewing at these places, just understand that a lot of these places will have similar problems, and it's going to be difficult regardless. But ultimately, if you're the trendsetter, the person who's the first person within a program, put your elbows out and move that culture, push them forward, and make sure that the next person behind you won't have the same questions and won't have the same experience. But that alludes to exactly what Rosny was saying earlier, is that there's a minority tax. There's an extra step of requirements, an extra step of work to be done, and it's falling square on the shoulders of BIPOC physicians and residency training staff and stuff.
So I am the external faculty liaison to the Howard students. I also went to Howard University College of Medicine, and they don't have an EM residency program, and they don't have access to EM faculty, so it's a little bit difficult for them when they're navigating matching into emergency medicine residency. So the advice I give them, I can give to any medical student matching into any specialty. And I say, when you're going on interviews, number one, obviously, yes, absolutely ask the DEI question, but break it down, not just in DEI, right? So everyone can tell you what they're doing for diversity, but you need to tell me what you're doing for inclusion. because inclusion is where my support comes in. Because if you're just diversifying without inclusion, that's violence. Don't bring me into an all-white space without support, right?
Yep.
And so asking them separately about their inclusion issues and how they're supporting their students or residents of color. More importantly, than, you know, the money is where your mouth is. How many of your faculty members are associate and full professors? How many chairs in your institution are of color, right? So if you're even bringing me into this institution, I see how inclusion works by how many people are holding positions of power in your institution that look like me. So, you know, I tell them to ask those kind of questions. And then I always say, ask the PD or whoever is extending this interview to you, especially since it's virtual now, to get the personal information of a resident or student of color that's there now. And I want to talk to them about their experiences. I remember I was interviewing at Harvard, when I was about leaving medical school and deciding on residency. And it was a majority white program. There's only 2 residents of color. And one was a wonderful Nigerian girl. She was a PGY4. And I remember pulling her to the side. This is when we were having in-person interviews, and asking her about her experience as a Black woman in Boston, right? As a Black woman at Harvard. And she, for like 10 minutes, went on and on and on about how she wouldn't trade her experience for the world, that Harvard was so amazing, that it's the name, you know, the kind of job offers she was getting coming out of residency were amazing, and the opportunities she had. And she said, you know, I mean, I get called a nigger like twice a shift. And wow. I was like, okay, so I didn't even rank the program, right? That is my sanity and my mental health are more important than the Hammer Harvard name, right? And so talking to a current resident in the program about their experiences and how they feel valued, how they feel that they are supported and cared for in the program is extremely important. You literally got to get the dirt, you know? And so those are 2 points that I really wanted to make. Also, I want to plug Dr. Heron's book for residents that are currently practicing. It is called Diversity, Inclusion, and Quality Patient Care, Your Story, Our Story, a Case-Based Compendium. I actually wrote a couple of cases for that book. Nice. And I think it really delves into those soft skills that we were talking about. There are lots of cases on attending resident interactions where bias was at play, or the resident felt like they were being marginalized by that attending, or, you know, the microaggressions. I think it's a great book for trainees to navigate that space as a BIPOC physician in training, not only to care for their patients, but to be able to advocate for themselves as residents of color when they feel that they may be being marginalized, or there may be microaggressions happening against them.
I think the other thing too is it's a small world. So I think once you start to meet people from your own institution and you'll meet people outside your institution, whatever your specialty is, it's a small world of people of color who are in these positions. And I think just having people to complain with sometimes is really helpful. So sometimes the complaining leads to action and leads to really good plans. And sometimes it just feels really good to de-stress. So I think that that's another kind of like resource is your peers and your colleagues that you work with as well. You'll learn a lot from them. And I think a lot of people are doing big things, so.
And then another plug, I'm going to put a link to the SAEM Diversity and Inclusion Resource Library, which was just launched this year. It's a really great resource of just like papers and, you know, articles and books and podcasts and websites that are all kind of great ways to educate yourself about these issues. So I'm going to put that link in the chat. I do want to move forward. So I'm going to shift gears a little bit. We've kind of touched on some of this stuff a little bit, but I'm going to shift just a little bit. Really incredible monologue that Dave Chappelle gave on SNL after the election, the election results. So he has this bit where he's talking about law enforcement and how, you know, a common refrain amongst law enforcement is feeling like they've got a target on their backs, feeling like the people that they take care of don't appreciate their efforts, and that they feel, you know, like they've got this target on their backs. And Dave Chappelle, in his way, rounds out the joke by saying, I know exactly what that feels like, and, you know, empathizing. I think that there are parallels that can be drawn. I mean, I've thought about this a lot. I think there's parallels that can be drawn between law enforcement and what we do as medical professionals, particularly in the ED. We work in chaotic frequently unsafe environments. We are frequently called to solve social problems that are outside our field of training and outside, like what we're really trained to do. And I think more than anything, I think there's a lot of fear. We're frequently kind of put in harm's way when we have agitated or aggressive or violent patients. I've had patients threaten me and say they're going to meet me outside and so on and so forth. And furthermore, I feel like I think the medical professionals in general can relate to this feeling of having a target on your backs, of this fear of, that you're one viral video, one mistake, one decision away from losing your license, losing your livelihood. So I want to know, I want to speak to, what does it mean to harbor at least some degree of fear from the population that we're called to protect and serve, and in our case, heal? What does that fear do to us as providers, and how does it impact the care that we give?
I'll let you go, Josh. Go.
Okay, just to better clarify, you're asking about the fear of a patient as far as our safety concern with regards to patients enacting harm on us, like belligerence and
and just
workplace violence. Oh, certainly. I think Marcee said it, had one of her anecdotes earlier about being in a room and with a patient and being considered that patient could be dangerous or so. I mean, I guess it's tough, certainly. I think a lot of the altercations that I find myself verbally trying to de-escalate and everything, and it's almost like a third person surreal experience of, am I being accused of, or am I lending to this society in which there's a supremacy, or am I being part of the issue, the institutional racism, the systemic racism, or am I now being placed in this opportunity to address this hopefully in a less harmful way, in a way that could be more advocating for the patient? And I try to lean more and more into advocating for the patient, even outside of my own comfort and everything. And so, and it has worked out well for me. And I'm speaking from a viewpoint of a male, and I feel physically strong enough to ward off of a physical attack. And so I have a little bit of privilege there, certainly, but even the verbal slights, and it's not always just the physical attack, right? And the verbal assaults. But I feel like advocating for the patient, when all else goes wrong, if I advocate for the patient, it has worked out well for me. There's certainly difficult interactions with substance abusing patients, with patients who have already been torn apart by the healthcare system and come in with absolutely zero trust, and having to work a little harder with them. But it is still the number one priority is their care and everything for me. And so that helped answer your question.
Yeah, I'm glad you acknowledged your privilege by gender, because my number one priority is my safety. I just at the beginning, the day I found out I was pregnant, I got assaulted by a patient. He kicked me in the stomach and knocked the wind out of me. The resident had gotten to see the patient. He was a little agitated, but like resting in his stretcher. And I went to talk to him, to examine him, and he just went from 0 to 60 and just kicked the crap out of me. And so I have to gauge every situation with my safety. So yes, I do carry that fear, especially as a woman, right? Practicing that kind of target on my back. Not just the psychotic patients who really don't understand the violence that may ensue, but the people who are just a-holes, the people who are nasty, the people who come to the emergency department with the premise that they either want to harm people or cause a scene or be difficult on purpose. And so, how do I give them care but keep myself safe? I have to come to the bed with a show of force to try to de-escalate. And even, the soft skills, talking to them in a lower voice, making sure that they understand that I'm not trying to enforce my power dynamic, but I'm trying to advocate for them. But making sure that I'm safe. So standing a certain degree away from the patient, making sure that there's an officer right close to me, that, the patient's right in their view. It's just my safety. I remember it's not part of my contract now, but my first year of the fellowship, I had to work at the VA, the Washington, D.C. VA, And they have hospital police, but their hospital police aren't hospital police. They're actually veteran affairs police. And they do not touch patients at all. It doesn't matter what they do. Unless they're arresting a patient, they won't touch them. And of course, it's the VA, right? So you have, you know, these war veterans with PTSD and all of these psych issues that come in all the time. And I had a homicidal 350-pound man with a machete that was like 16 inches who came in saying he was going to kill us all. And I asked the veteran police department to come in to help me subdue him. And they're like, well, has he committed a crime yet? I'm like, no, but he's going to chop us all to pieces. And they're like, well, call us when he does.
Wow.
You know, and I was actually 9 months pregnant at the time with my second daughter. And I had to try to talk this man down to put down his machete. You know, 9 months pregnant with my child, single attending coverage without the help of any police, right? And so I had to advocate for myself to my chair, like, hey, you make me work the VA again, I'm quitting. You know, and so he revised my contract. But I do have that healthy fear of patients because some patients are out to actually harm you, unfortunately, you know, and so as much as I want to advocate for everyone, and I will try to advocate for all my patients, I pride myself on making sure that I'm their advocate. My safety is also my priority because the Hippocratic Oath did not say that I have to lay down my life for my patients.
Absolutely.
Wow, what a stark contrast, you know, and I'm not in Los Angeles, so I don't have the inside knowledge on this case, but there was actually a patient recently who was shot by the hospital security in the emergency room, if I understand that correctly. And so, you know, it just, I think, highlights how we are in such a wide range of interactions just in the span of what we've been talking about, the range of being upset at the police being too aggressive, not being aggressive enough, where we fall. You know, and I was thinking about this scene from one of my favorite movies, Selena, where she says, we're stuck in the middle. We gotta be more American than the Americans. We gotta be more Mexican than the Mexicans. You know, it's kind of where we fall, trying to bridge the gap between the you know, this healthcare system and our patients.
Yeah, I think we could go for, this could be a whole nother talk because I think safety is a difficult thing. I kind of am thinking about this slightly differently, kind of in two ways. One is I think a lot of people don't know this, but the Civil Rights Act from 1964 actually is supposed to protect us from bias and aggression from patients. So that's something that is federal law that a lot of people don't know. And if you look at most of your hospital's policies, it should be written into there that you shouldn't be subject to these things. Of course, it's different when patients are, you know, psychotic or don't have capacity for whatever reason or whatever they're suffering from or experiencing. So it's a difficult thing with a lot of gray area, but that's something to be aware of. Because I think that there are, you know, definitely those patients that we interact with that where it's not necessarily physical violence, but a lot of that, you know, target on your back is, oh, if I make a mistake, or like this person thinks I'm not a good enough provider because of my age or my perceived gender or sexual orientation or ethnicity or whatever it may be. So I think that's a kind of different aspect that we have to deal with quite a bit as well. And I think that fortunately, I think the vast majority of people will be reasonable if you show them respect. So I think that people are in a very vulnerable position when they're in the emergency department. So like, you know, the amount of people I've treated who have gigantic swastikas tattooed on them, like most of them have been really polite to me. I don't know if it's because I am like, you know, I don't know if it's because I'm ethnically ambiguous or because like, you know, when I talk to them, I treat them with respect. But I think the vast majority of them, if you say like, look, the position that we're in right now is actually a place where I can help you and I want to help you. And that's like what I'm here to do. If you start becoming like aggressive with me and racist and biased and I give you one warning and, you know, you choose to transgress me again, like that's a different story. But I think that most people, if you have a reasonable conversation and treat them with respect, you know, it's an interesting position where we actually, I think, have some privilege there that we're in a place to actually help them, give them medications for their infections, their pain, like whatever. And it's a place where we can make like inroads with people in some ways.
I think that Minerva brought up a really good point in the sense that Minerva and Marcee, because, you know, as a woman, our safety is paramount, and we have to, I'm constantly thinking about, okay, is my back to the door? Like how much distance there between me and the patient? And I think that we're in a very precarious position, because on one hand, I want to know that if things get out of hand, I'm not a security guard, I'm not a bouncer, I don't know how to physically, I've learned, but I wasn't trained in the art of restraining a patient. So I want to know that when I call security, they're going to come and they're not going to shoot the patient, that they're going to be appropriate and respectful and know their limits, and that they aren't also acting out of anger or aggression, and that they're not going to further escalate the situation. And so it's this very weird scenario where it's just like, come help me help this patient. Don't kill them. We're not trying to, take this person out of, it's never okay. I think that's the primary, distinction you can draw between what we're called to do and what law enforcement do. It's never okay. It doesn't matter how many times a patient threatens me. I can't just kill them. I cannot respond in kind. I cannot respond. It's never appropriate. It's never okay because of what I'm called to do. And so, I think that it's a very strange position that we're in the sense that we are always thinking about, okay, how can I help this person who is waving a machete? How can I help this person who is clearly distressed and agitated? What do they need from me? And it really takes a lot of, and again, we're able to see that because if it just so also happens that this patient is the same background as me, I can at least fall back on like, okay, what are we missing? This person looks like someone I know. This person looks like my uncle, my cousin. Maybe there's going to be some kind of maybe we can kind of reach some kind of common ground. If I don't have that, if I were a white person, if looking into the situation, maybe they don't have that same connection. Maybe they look at that tall, aggressive Black man and they don't see a person anymore. And that's the scary part, is knowing that I can still see this scary person, as someone who probably doesn't act like this every day, and probably has a whole bunch of factors contributing to why they're behaving like this. And I can still see this as someone who is perhaps a reasonable person in any other situation. And if you don't have that same perspective, if you don't have that just awareness of these are still people that we have to care for, I think that's the concerning part.
Yeah, we have a couple of different institutions we work at UCSF, and the policies are slightly different for security versus, we actually have sheriffs in one of our hospitals, and it's been an ongoing conversation of how do we, especially in light of a lot of police violence and media hype around police violence, et cetera, like how are we having these conversations, and how are we figuring out how to work with the entire staff in the hospital in a way that's safe and equitable and just, because I think we all know that our patients are certainly probably more at risk if they come from marginalized backgrounds or the people of color when interacting with the police. And we talked earlier about like the increased risk for restraint, et cetera. So there are increased risks from medical providers too. So we've been really working hard to have conversations, and what's difficult about it is not being inflammatory or accusatory, and instead of in the moment responding and saying like, okay, run here now. They might be scared. We might be scared. The patient's scared. Who knows? There's all these emotions, as opposed to, well, can we come up with like a plan, because we know this will continually happen, and like, what is going to be our plan for how we work with our security officers or our safety officers or our violence intervention folks and our patients to actually make people safe when they're in the hospital. And I think about that, especially for our patients who don't speak the same language, and who are people of color, et cetera.
So I know that, so we're drawing to a close, and I want to close with just a question to each of the members of the panel. We talked about a lot of really heavy stuff, and all of these things are issues that we carry around from day to day. What are some of your self-care rituals? How do you decompress? How do you kind of get up every day and keep going?
I'm sorry, I laughed because I have 2 small toddlers, so I don't have self-care anymore.
Oh yeah, what is self-care?
I haven't slept a good sleep in 3 years. So I mean, I will probably engage in self-care in the next like 3 years.
Yeah.
I'll come back to you.
I personally have a therapist I started seeing, especially like once the pandemic hit. So that's been really nice. And, you know, I used to think that that was for people who had like big issues, and I probably do have a lot of big issues, but I think it's just something where it's a space to talk and think and reflect on what's going on in my life once a week. So that's been really powerful for me, and trying to stay active. So I try to get outside or, you know, ride the spin bike inside as much as possible to just like clear my mind. I never feel worse after doing it. So for me, those are two of my biggest things. And also doing like mentorship makes me happy.
Nice.
I love the mentorship aspect. That sounds like a great plan. But yeah, I don't have kids, fortunately, so I can engage in some self-care. But usually when times are rough, I always lean back on the people within my community. And it's even more helpful after going to Howard University College of Medicine that like many of these people are physicians and part of my community, and I'm able to reach out to them and tell them about what's happened, or even just hang out and not be doctors for a minute. And within our practice at Beth Israel, we had 4 African-American male attendings. Alden Landry is one of them. He's actually plugged me into this. I'm sure plenty of you know him. But even just sitting back and watching a basketball game with them, or I'm also part of the LGBT community, so I can hang out with some of my friends within Boston. And sometimes just forgetting that you're a doctor for a day is just the way to do it, and just being a different person, your normal casual self that you were before you got the degree, and who you have to be at work. And so.
Yeah, I'll say pre-COVID, I did a lot of the same things, run, kickbox, walk with my dog for long walks, and spend a lot of time with friends and family. I think since COVID, it's just been giving myself permission to feel bummed out like everyone else, and to just, you know, try to keep my head above water, and to have that sort of understanding that just because we're inside doesn't mean I have to be just as productive as I was before.
Fantastic. Well, I just want to extend a really warm thank you to our panelists. Thank you guys so much for coming on, and thank you to all the viewers and participants for your questions. I think this was a really good discussion. I hope we can have more in the future. I look forward to future town halls and future discussions. Thank you guys. And you guys are all amazing physicians, and I feel really honored to know you.